Good morning. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System, broadcasting live with you from the Dolph Simons Family Studio, and delighted to be back with you on this brisk, cool Tuesday morning here. And I'm here, of course, with Hawkeye, my partner in crime, as we go through this morning's events related to coronavirus. We're also joined by renowned scientist Dr. Gregory Poland. He is a renowned vaccinologist, a physician scientist, and the founding and current director of Mayo Clinic's Vaccine Research Group. Dr. Poland, welcome on our program today. We're delighted to have you. He's also the editor-in-chief of the journal Vaccine. These are but a few of his wonderful accomplishments, and we look forward to our conversation with him today. But first, Hawkeye, how are we?
Numbers. We jumped up a little bit.
Yeah, I figured.
So not a good thing. Just under 100 now, 94 active patients in the hospital. I think we had 84, 85, 86 yesterday.
Yeah, we're up.
Unfortunately, a large proportion of those are ICU patients, so 52 ICU patients of the 94 active infections.
So over half.
Yeah, and 25 of those are on the ventilator.
That's actually a little better than yesterday. Yesterday was 28 on the vent, so that's better.
We do have 62 people in the hospital that are in that recovery phase and 6 that are still on the ventilator as well. Hayes, their numbers are about stable, so 28 total patients, 24 active, and 4 in that recovery phase. So unfortunately, our numbers here at the hospital have jumped up, I think pretty significantly. There were some discharges, but of course, the overall admits were much more than the discharges. So.
Okay. Well, that's not exactly the trend we wanted, but it's not a surprising trend when we look at that rolling 7-day average here in Kansas City and the number of cases each of the last 3 days. Now, down yesterday a little bit for the metropolitan area. I think it was around 900. Before that, we'd had a couple of days, but that 11 to 1,200 in our metro area in a row. So we kind of curved down a little bit. Less testing, I think, is probably a part of that story. Testing has begun to escalate out, and so we're seeing more cases. And the percent positivity remains pretty high.
Yeah, it's very high.
And it's high throughout Kansas. All right, Jill, let's see if there's any questions from reporters to start our morning.
We do have one, and it's actually for your guests. So do you want to?
Yeah, let's go to Dr. Poland then, because I think that would be a better deal. So, Dr. Poland, welcome to our program. Thank you for being with us today.
Thank you. Good morning.
And as much as I want to say it's a little chilly here in Kansas City, I'm going to bet it's a lot chillier in Rochester, Minnesota.
Always.
Is there snow on the ground?
Well, I'm actually sitting in Florida right now, and it is about 62 degrees here, so it's cold here, too.
Yeah, but there's no snow on the ground.
No.
All right, so you're down at the Mayo Clinic in Florida. That's a bit warmer down there. And how are things going in Florida overall with COVID?
We've got a problem here, and it's a cultural problem, much like Kansas and Missouri have, where we can't really get people to follow the hands, face, and space recommendations, and we're paying the price for it.
Yeah, we've tried that here. And I would say in our metropolitan area, we're seeing a lot better masking than we were even a month ago. I think we've gotten that. I think that's escalated. But man, if you get outside the metropolitan area, that begins to change pretty rapidly. And still, restaurants, bars, homes, other churches, other places of public gathering, not seeing quite the right behaviors there.
No, it's irrational, frankly.
Yes, it is. And we've been trying to say, we've been saying that. I think we may have used that term along with a few other terms throughout. So tell us a little bit, what's your general opinion about the state of vaccinology? And again, a special announcement this morning, you heard me kind of say you get those little news alerts and it says, the FDA says Pfizer and BioNTech vaccine meets success criteria. That's a big statement.
Yeah, well, they have clearly met the success criteria. I've been through the briefing document. There is no chance that this vaccine won't receive an EUA after the FDA meeting. This is by any measure, this is a home run.
Yeah, when I saw it, I was at 95%. That pushes you up there with things like smallpox or measles and other vaccines. I mean, that's really impressive work.
Indeed. And, what was particularly interesting to me is that the point estimate of efficacy after one dose, depending on who you were looking at, varied between 50 and 88%. And that was a bit of a surprise to me. I did not expect that high of efficacy after a single dose.
So tell us what that means in lay terms about, do we still need 2 vaccines, and why? What does it mean to have 50 to 80% on one dose? And to help us understand a little bit about what that implies.
Sure. So what they did, of course, is they're giving 2 doses 3 weeks apart. So after the first dose, they looked to see what kind of efficacy they would have. In other words, among people who got 1 dose of vaccine versus those who got placebo, was there a difference? And there was. There was a wide confidence interval, so we wouldn't take this as gospel yet. Then, of course, at 21 days, they got their second dose, and they measured efficacy 7 days after that and found an efficacy measure of 95%. Impressively, that estimate really did not vary by age, gender, race, comorbidities, and that's why I call this a home run.
Yeah, that is a really big deal. And by efficacy, we mean it produces antibodies. What do you mean by efficacy?
Sure. Efficacy means that you're actually measuring a difference in infection rate. So did it prevent, was it effective in preventing infection with SARS-CoV-2? So
you ready to roll up your sleeve?
I am.
I am too. Let's go. I'm ready to go. All right. So, and tell us a little bit about what does it mean to be a messenger RNA virus as opposed to perhaps the ones coming out from AstraZeneca or J&J?
So both the Moderna and Pfizer are mRNA vaccines. So what that is it's the genetic code for the spike protein. It is not the code for the whole virus. It's the code only for the spike protein. That is encased in a fatty or lipid particle injected. That mRNA gets into the cell, not the nucleus. It cannot get anywhere near our chromosomes, and then uses our own cellular machinery to make spike protein. That spike protein is then introduced to the outside of our cells where immune surveillance cells see that and begin to produce an immune response, primarily antibody. And that's what protects us. So we're basically tricking the body into thinking that it is seeing coronavirus.
And that spike protein can't attach itself to another virus and cause trouble. So it's just, right? I mean, it's just out there, and then our bodies can recognize it when we get coronavirus.
Exactly right. So if you were to be exposed to it, your body would say, aha, I know what this is. This is coronavirus. It starts, cells start elaborating chemicals that are basically saying to other immune cells in our body, hey guys, come over here. Here's the foreign invader, kill it.
That sounds like a good plan. And so what percentage of the population do you think needs to get one of these vaccines in order to get to that magical herd immunity concept?
Yeah, probably somewhere around 70% is the best estimate. Nobody knows, and of course it's going to vary a little bit by location based on seroprevalence of antibody from people who have already gotten infected. But the ideal, of course, is that everybody get the vaccine, because there will be a small failure rate, as there is with every vaccine. For example, again, if we take the point estimate of 95%, that means 5+% of people won't be protected.
So this sounds like a much better idea than the Barrington report concept of running out and let's all go get herd immunity by all getting sick at the same time unless you're over 60 years old or have chronic comorbid diseases and other astonishingly bad ideas.
Yeah, I guess my best answer for it would be that Tony Fauci called it unethical. I think we've learned that lesson. Even Sweden has now rejected that possibility of reaching herd immunity. They suffered an enormous number of deaths compared to countries around them that did not engage in this. And so they have rescinded that policy.
Yeah, those were smart people. I wonder what they were thinking. So in your opinion, is the race to get the COVID-19 vaccines out too fast or too slow?
I think it's been, kind of the Goldilocks situation. It hasn't been too fast. It hasn't been too slow. Now, you might be astounded that I would say that, but here's the important thing. Let's just take the mRNA vaccines. Development of those started in 1990. Okay, so this is 3 decades of developing the technology. mRNA vaccines were developed for SARS in 2003 and then sort of shelved because that epidemic spontaneously ended. So it's not like somebody decided 9 months ago, hey, let's come up with this great idea and build a vaccine and start testing it. Work had been in progress for decades. So this was ready to go and just needed to get the S protein inserted into this vaccine construct. That's why it could be tested so quickly.
Yeah, you know, I'm a Star Trek guy, and in Star Trek, they just kind of make them over in a couple of hours. And I think that we obviously would like to get to that. In the meantime, we have to do this.
You know, the one thing, I will say that efficacy is something relatively easy to detect and to measure. Safety is a bit of a different thing. So what we have now is between 2 and 3 months of safety data after the second dose. Why is that number important? 95 to 100% of any serious vaccine reactions occur within 6 weeks of receiving a vaccine. So this is several weeks after that. So what I would consider our safety data to be is the floor. We don't know the ceiling yet, and you never do until hundreds of thousands and millions of people have gotten a vaccine. But I don't expect anything different than what we've seen because of that time interval.
Yeah, that's such an important point. And, you know, it's interesting. People get nervous. Well, there's only 15,000 people in the study. And yesterday on the program was one of my colleagues, and he and I are both CF docs. And you know, in the CF world, man, we get 200 patients in a study. We think it's a big deal for safety. That's a big number. So 15,000, 30,000, those are really large numbers when it comes to efficacy, especially over a short period of time like that.
Well, even in the vaccine world, those would be very acceptable numbers for a vaccine. And oftentimes, we're looking at more like 5,000. Now, rotavirus got up to 60,000, but you know, this is fitting right in that ballpark.
Yeah, if only this could be rotavirus and not coronavirus, SARS-CoV-2. So tell me about the differences between the Moderna vaccine and the Pfizer vaccine. And do you have more faith in one than the other conceptually?
Well, you know, what I like about the Pfizer vaccine is that it did increase the number of cytotoxic CD8 cells, which may be something important in clearing infection that would occur. Moderna has not reported that. That doesn't mean they don't have that data, but we haven't seen it reported. The main difference is in sort of the storage and logistics. So with Moderna, you have to keep that at -20. You can refrigerate it for up to 30 days, and you can have it at room temperature for 12 hours. That's easier logistically than the Pfizer vaccine, which requires storage at -75, which in American parlance would be about -104 degrees Fahrenheit, so significantly colder than Antarctica. You can only keep it refrigerated for about 5 days and at room temperature for 2 hours. So that does induce a logistical and administrative burden on people as they're trying to receive, store, and administer this vaccine, particularly in any sort of mass administration.
Yeah, I think that and we've been reading about the actual storage site for the Pfizer vaccine. And Dana, you can talk a little bit, but I know we've got the freezers; they're ready to hum. Yeah. For all I know, maybe the vaccine's there yet. I don't know.
Yeah, you know, we do have plenty of space for that. We are working in conjunction with the medical center. They've been very helpful, but we also have our own here with the health system as well. So we are ready to go. We have plenty of volume to be able to store a huge volume, you know, up to 350,000 doses, should we need it, if they can deliver that many. But we know that there are some shortfalls that are being predicted on the initial deliveries as well. But
any thoughts about the U.S. government? As I read last evening, we've ordered the first tranche of vaccine, but the second tranche we didn't get ordered, and now it's gone to other countries. What happened with that?
I saw that same report, and it's a little bit puzzling. You know, certainly with this being the first vaccine out under an EUA mechanism, you'd like to have as much of it as possible. Now, their production capacity starting in January significantly increases, but instead of 100 million doses by the end of this year, I think Pfizer's talking more about 40 to 50 million. And remember, this is a 2-dose vaccine.
Yeah, so that was a little unfortunate, but I think the Moderna one they've got locked in a little better. So hopefully that one will have the same degree of efficacy. Well, let's turn first and see if there's any reporter questions, Jill, and then we'll go to our listening audience.
So I have one from Fox that was sent in, and then I've got a couple of more. The question from Fox is for Dr. Pollan, and they want to know what you think about the CDC issuing vaccine cards. Is that helpful?
Vaccine cards, and that's what that's what they saw. They did that in Britain, but I guess they do that with a lot of vaccines in Britain. So, what do you think about a vaccine card here in the U.S. and other ways to help identify who's gotten it?
Yeah, I mean, I think it's fine. You know, up until recently, at least prior to the electronic medical record, we issued vaccine cards. So you came to the Mayo Clinic, got a vaccine, you got a card that indicated that you had that. That was important because of the lack of electronic medical recording systems for that. The question is, what will they do with the card? In other words, if the card is going to be used as some kind of immunity passport or some sort of requirement to work or to go into certain facilities, you know, then it raises questions about, is this your card? Is this card real? Is it counterfeit, et cetera? So the card itself, I have no problem with. It's what will the card be used for?
Yeah. So that leads to a question about, should people be required to take a vaccine? Is Mayo going to require employees to be vaccinated?
At this point, no. And I don't think, other than perhaps some very defined circumstances, I don't think it's appropriate to require or mandate a vaccine when it's under an EUA. Now, once it's a fully licensed product, I would hope that medical centers would do what they did with other highly transmittable respiratory viruses like influenza and require it. And I believe that based on professional ethics, that we have a moral responsibility to not transmit viruses and diseases that are dangerous to our patients when there's a safe and effective vaccine available.
Yeah, I totally agree, and that's our health system stance too that we've developed. Because it was only on the EUA, we were not going to require it, but going forward in the future, hopefully, because it works so well and has so few side effects, we'll get there. Jill?
Fox is also asking for some clarification. News reports have said that RNA is made from synthetic genetic materials. Is that accurate, and what does that mean?
Dr. Pollan.
Yeah, so, you know, literally what they do is this is a code. It's just a series of nucleosides. So what they do is they chemically synthesize the string of letters that compose the mRNA. And that is what's used as the vaccine. Now, you have to do a couple other things to it. It degrades so quickly that you have to encase it in a lipid particle. And then you have to do some nucleoside modification. That is, you have to modify one or two of these string of letters in order to prevent it from being degraded too quickly.
And, you know, and I think, you know, just Dr. Pollan said before, these have been used for decades. So creating mRNAs is nothing new. These are done in laboratories all across the United States, all across the world. They don't make the amount that is needed to make all of these millions of doses. They make very, very minute amounts. So there is a huge process to make enough of this mRNA to get in that many doses. But this is a process in the lab that has been done even longer than the couple, 3 decades that Dr. Pollan had talked about for the vaccine technology. So this is a very old technology. We have to remember this virus is an RNA virus, so we are creating these mRNA strands from the original RNA that is used in the genome of the virus itself.
And Dr. Pollan or Hawk, as I recall with SARS-CoV-1, the very deadly, but not as transmissible or communicable, fortunately. Did anybody get that vaccine?
Only in clinical trials. So certainly monkeys, for one, got it. And I believe there were initial phase 1 trials. I'd have to go back and check on that. But, that faded so quickly that it certainly did not involve a lot of people.
Yep. Okay. Jill?
All right, another media question, and then we'll move on to community questions. KCTV5 is asking, with 95% of efficacy, do we achieve herd immunity?
Will we achieve herd immunity? We talked about that at the beginning of the program, but we might want to explain that. Let's hit that a little bit harder.
Yeah, so the idea of herd immunity, just to step back a minute, is imagine a circle of, 100 people. If everybody is susceptible and it's a highly transmissible virus, then everybody or nearly everybody gets infected if one person gets infected. The more people you have in that circle that are immune, the less likely it can spread to the susceptible people. So what is that cutoff? How many people need to be immune before you don't spread it widely? And that answer has been proposed as somewhere in the 70 to 70+%. So the idea behind herd immunity is get people immune as quickly as possible with the least adverse effects as possible. And that's a vaccine, of course, not the disease. So the idea would be, can we immunize a large enough number of people to stop transmission of the virus so that we protect people who cannot get the vaccine or who are unlikely to respond to the vaccine? For example, as you might imagine, people whose immune systems are compromised, either because of a disease that they have, like cancer, or a treatment that they're getting. They may not be able to respond to the vaccine and be protected. The people around them, however, can get the vaccine and be protected, as well as protect those vulnerable people. So that's the idea behind herd immunity.
Yeah, and so I'm, as I said earlier, I'm looking forward to having. So we can go to the Royals games, to the Chiefs games, and I guess where are you, Jacksonville? So that means you're a Jaguar or something like that.
Well, no, I'm a Vikings fan.
That's even worse.
God bless you.
Go Bears.
We suffer living in Minnesota, and we suffer with the Vikings.
Well, we suffered like that for many generations, and then Mahomes.
That's yes. But I think to the point that was brought up, I don't think the general population understands the amount of people that are out there with these immune deficiencies. So just general things that you wouldn't necessarily think about. I know when I see my HIV/AIDS patients, I have to wait till their CD4 counts, their immune system is built up enough before I can give them vaccines. We know that people with liver disease, with end-stage liver disease or high-grade liver disease, if we do a vaccine series, say for hepatitis B, they don't mount an immune response, so we have to give them double dose. We don't have a lot of information about this vaccine in those specific populations, but moving forward, I'm sure we will get that. But it is important to understand that some people may not be able to, even if they can get the vaccine, they may not mount a response. So Dr. Pollan's point about everybody around that person who is vaccinated and immune can protect that person indirectly.
So, Dr. Pollan, how do we get people to want to be vaccinated? We're devoting this week to that aspect of around vaccinations and here in our program, and we're going to do more around that. But especially in minority populations, and especially in African American populations, where there's been a lot of experimentation historically. Not a lot of trust necessarily in some of this science. So, how do we convince people that really we're trying to do the right thing?
Yeah, I mean, I'm on several work groups considering that, and it's a tough question. I don't have an easy answer. The way I would formulate an answer, though, is this way. I think you have to have a trustworthy message and a trusted messenger for that community, right? As scientists, what do we want? We want a credible scientist who can actually give us the data and assure us that things have been done well. And each community is going to have different informational needs. Some of it, basic and cross-cutting across all groups, but others are going to want reassurance that this is safe and effective maneuver to do.
Yeah, I think it's going to take a lot of time, and I know we're trying to work through some of those questions right here in our own backyard, and it's so important because in the long run, the pain of not believing is going to cause, I think, a great deal of concern for individuals and for families. So I think
the other aspect about this, and here I tread on dangerous territory, but it's a little bit like faith. You can't prove faith. Faith is faith. You take it on faith. To some degree with this science, you will never completely convince people who are not scientists. And there comes a level at which they have to take it by faith that the trusted messengers they're hearing from know what they're talking about and are telling them the truth.
Yeah, I think that's right. So Hawk and I have pledged on our program, at least, that we're going to roll our sleeves up and get our shots right here so everybody can see it. So there won't be any question about what we're doing.
You know, I think that says a lot. Absolutely. You know, we can't just talk it. We've got to walk that talk.
Absolutely. And we did it with influenza. We're going to do it with this vaccination as well. And then I think we have to look toward community leaders and faith leaders and others to try and help get a message across that we can take care of each other by doing that. One of my greatest fears, and I'm curious to see your thought about this, that sometimes if you think about it in different circles, there's a large intersection between those who don't want to wear masks and some of the people who don't believe in vaccine. That feels like a very vulnerable group of people.
Yeah, no question about it. We have seen, and I'm sure you all have too, one story after another. They are emotionally wearing on me, of disasters that occur in families where they say, we had no idea this could happen. We had no idea you could die from this, or you could have a stroke like this. And yet, I'm amazed. If you have ears to hear and eyes to see, how could you miss this information? And the reason for it is something psychologists call belief-dependent realism. And what that means is that people make up their mind, usually conflating it with either religious or political ideology, which is inappropriate. This is a scientific and social issue, not a political per se or religious issue. And they make up their mind about it in the absence of data, and no data will change their mind. And that's a very dangerous thing. What I've often said is, worse than influenza or coronavirus is ignorance. Ignorance is what kills.
Well, and it's especially striking when some of our most prominent leaders refuse to acknowledge that and be a part of that. So,
yeah.
Jill?
We have a lot of individual questions from people that are asking, for example, I'm a nurse and a nursing mom. Should I get the vaccine? Or I'm a transplant patient or a candidate. Should I get the vaccine?
All right. Well, let's take some of those categories on. In your mind, and I think certainly our policy will be that the frontline healthcare workers who are constantly exposed to coronavirus will be the first in line in our institutions, at least, to get it. And we've tried to make the point over the year that we've been doing this program, or nearly 9 months now, that really, if you want to study how to prevent coronavirus, or COVID-19, just go look at the cohorts of patients in our hospitals where we don't see disease transmission to our staff because we have good safety precautions and good infection control precautions. But those folks are going to be the first ones, and at least in our institution, to go ahead and get the vaccine. Comment on your sense of how that vaccine is going to get distributed in the U.S. and the front line, and who should be getting it first, and then we'll cascade to the next questions.
Yeah, you're exactly right. Mayo Clinic will be doing the same thing. Our frontline healthcare workers, front-facing healthcare workers, are the ones that are going to get the vaccine first. Next in line, of course, are the elderly, long-term care. You asked about, a breastfeeding mother, for example, or somebody who's a transplant. And let me clarify. We don't have any data in those groups. In other words, those are individuals that were excluded from all of the current clinical trials. So any decisions we would make would be an extrapolation from the data. And I always want to be very transparent about that. It's not like we have direct knowledge, we would have indirect knowledge. My sense is that there would be no danger in giving it to a mother who was breastfeeding. I don't see anything biologically by which that could be a concern. In terms of transplant patients, my concern there is that they simply would not respond well to the vaccine. Not a safety issue with mRNA, but would they actually respond with protective immunity?
Yeah.
And I think, and I know that you deal with this on a daily basis, the anti-vaccination group, and what are the low-hanging fruits as to why I'm not going to get this? We've addressed safety, but there's also things out there, especially in social media, about infertility, and we talked about this a little bit. Can you give us an answer if a mother or a couple is not wanting to get the vaccine because of infertility fears?
Yeah, there is zero evidence of any effect of the vaccine on fertility. However, we do know that 5 to 10% of men who get infected with the virus can have that virus detected in semen, and it degrades sperm quality. So the issue is the fear or the concern should not be about the vaccine, but about the virus itself.
Yeah, and I think the other question I would have is, who do you feel like, as you look at the different disease states, those with hypertension, those with COPD, those with cancer, who do you see as being the most vulnerable patients?
Yeah, the interesting thing, and now we could go a long time here because this is what my lab studies, basically trying to
I knew you had to know I was going to get there eventually, right?
We basically think there's both a clinical and a genetic signature that would predict who is going to have severe disease or various complications. And that's a function of age, of gender, of racial category, of blood group, and comorbidities, and other genotype issues that we don't yet completely understand. So, if we just pick certain categories, we do know that any degree of overweight or obesity is adverse in terms of developing more severe disease. The same is true with diabetes, cancer, heart disease, and any of those kind of chronic medical conditions that are the bread and butter for what we do as internists, represent an increase in risk for more severe disease.
Okay, so what's the blood type of the moment? Because I know that A negative or A blood type was terrible. Then it was good. Then it was terrible. Where do we end up on A? I'm asking that because I'm an A blood type. I'm just curious.
Yeah, you know what? I'm an A negative myself, so
there's not many of us.
I looked at this data pretty hard, and my conclusion is that has pretty well stood up in very large studies. So, my wife's an O. She gets off scot-free. The Bs and the ABs are somewhere in between, and us As are leading the way.
Take care of each other, Dr. Pollux. That ain't negative. There's not that many of us. Okay, Jill.
Okay, we got a lot of questions. Let's see if we can rock through some. Sam wants to know, in following up to the degradation of sperm, is there any evidence that it leads to erectile dysfunction?
SARS-CoV-2.
Yeah, I didn't expect to come on the show and have the talk with Kansas, but I am not aware of any issues of erectile dysfunction. Outside of somebody being acutely ill, and that's a different mechanism. But I'm not aware of coronavirus causing erectile dysfunction over the long term.
Well, some things are bipartisan.
Yeah.
Jean wants to know, if someone has been vaccinated, can they still infect others with COVID if they catch it?
What do you think? I know that's an area of controversy still.
Really good question. That's a really insightful question. And in the FDA briefing document, there is a hint that it could prevent asymptomatic infection, but we don't know that with clarity yet. So somebody who got vaccinated could transmit virus under two conditions. One is they did not respond to the vaccine, so they're not protected. And the other is, and this is where we don't yet have clarity, we know that the vaccine prevents symptomatic infection. Does it prevent asymptomatic infection? That's for mRNA. I will mention one piece of data. In the AstraZeneca study, now that's a different vaccine. That's an adenovirus vectored vaccine. In their non-human primate study, they were able to immunize monkeys, then challenge them with the virus. In some of those monkeys, they could identify as much virus in the airway among the immunized and challenged monkeys as they did among the non-immunized and challenged monkeys. So this remains a bit of an open question.
Yeah, that's a little concerning because then you could still be transmitting it pretty easily. It just really means everybody needs to be vaccinated.
Exactly.
So how long do you think we're going to have before the masks come off and we can gather in large public places?
You know, I'm glad you asked that question because I want to make a point that seems to escape the notice of my fellow scientists. Remember that these efficacy studies, think about who joins a clinical study in general. They are people more concerned about their health. So these efficacy studies have been conducted in an era where, for the most part, these folks have worn masks, observed physical distancing, and hand washing. So the question becomes, what is the efficacy of the vaccine when those conditions are not being followed? And we don't know yet. So let's just say that it maintains reasonably good immunity. If we get a very large proportion, and that's where I'm saying 70, 80, 90% of the public to take these vaccines, we will get back to some degree of normalcy rapidly. The paradox of the people who are not following masking and distancing is that we are going to lose many more Americans than we needed to and have this pandemic interrupt our lives for many more months than it needed to. You know, the best estimate right now is that by the end of the first quarter in 2021, and I'm glad you're sitting down, the best estimate is that 1 out of 700 Americans will have died of this virus. And yet we can't be inconvenienced with wearing a piece of cloth over our face.
That I struggle with. There was an obituary from a man who had contracted the virus, and it's from southwestern Kansas, I think. Yeah. And the obituary is powerful. I don't know if you saw that, but that was really powerful, I thought. And we'll make sure we bring that on the program. But you know, it speaks to the sacrifices this man had made, beginning with the Great Depression and then serving in the war. And now people won't wear a cloth over their face to take care of each other, and that's disturbing.
Sally wants to know, you stated they measured efficacy 7 days after the second dose and then defined the efficacy as transmission prevention. She wants to know, was 7 days enough time to measure that?
Yeah, efficacy was not defined by transmission. It was defined by having symptomatic disease. So in other words, the way efficacy was measured is, did the person have evidence of disease 7 days or more after the second dose? You have to give time for the second dose to work, which is why they chose 7 days.
Bob wants to know, how long does immunity last?
Oh, that's a $60 million question here.
You know, I know the answer, but I can't tell you. No, I'm kidding. I'm kidding. We don't really know. Here's what we can say. We know that there have been well-documented episodes of people who actually had wild virus infection. They were symptomatic with the entire virus infecting them, and then many months later, 5, 6 or more months later, got reinfected. We don't know how often that occurs. We've only seen the tip of the iceberg. Presumably, this could happen with the vaccine too, but it's too early to know this. Remember that oftentimes when people are asking about long-term issues, there is no long-term yet with this virus. this canvas that we call COVID-19 was blank 10 months ago. We've put a lot of pixels on the canvas, but there's a lot more to learn yet. And so no one can really tell you what the efficacy will be as 1 year, 2 years, et cetera, goes by. Best guess is that there will be people in whom immunity will wane sufficiently to the point where they become susceptible again and would need a booster.
Isaac wants to know, he says, I've seen lots of Facebook comments from people who voice concerns about possible long-term side effects of a vaccine. Does that worry you?
Are you concerned about some of those long-term side effects? We hear about the transverse myelitis that may or may not have happened when the AstraZeneca trial and things like that. Talk to us a little bit about that, Dr. Pollan.
Sure. You know, let me just first get kind of a fact out, which I think helps to set the stage. In the field of vaccinology, we do not see vaccine side effects occurring after about 6 weeks after receiving the vaccine. So vaccine side effects tend to occur within minutes to days. The one exception was Guillain-Barré syndrome, a kind of paralysis that has been associated with. Nobody knows if it causes, because other diseases cause it, but associated with flu vaccine. And that occurs about 1 in a million. And that can occur up to 6 weeks after receipt of the vaccine. That is why a few months ago you saw the FDA issue a guidance document asking for a minimum of 2 months, that is 8 weeks, as an additional safety margin. What will happen is every week that goes by, since those people received 2 doses, and now we're getting to the point where there will be people with 12 weeks and 14 weeks and 16 weeks since the last dose, and they're not seeing any evidence of those long-term side effects. Now, legitimately, you can say, we don't know what we don't know. And that is true. So we would have to postulate some currently unknown biologic mechanism that would be responsible for some kind of side effect that would occur months or even years later. I just don't see any biologic plausibility to that. I don't see any evidence with any vaccine of that happening. So I have to conclude that the risk of that is so low that we would be foolish to reject a vaccine on that basis, given the very real and present and large danger of the virus.
Yeah, the virus really kind of overwhelms. You want to think about side effects, so long-term side effects, think virus, not vaccination. So as you look at it, AstraZeneca, Moderna, Pfizer, you mentioned the Pfizer. Do you have a preference between those three or even the J&J vaccine?
You know, I really can't express a preference at this point. What we can say is that we have more data for the mRNA vaccines simply because they're first through the chute, so to speak. The other thing is that the phase 3 trial data have not been published and peer-reviewed yet, so it really wouldn't be fair for me to comment on that.
Now, there are a number of other vaccines that are coming up beyond. We talk about these four all the time, but there's a lot more behind that. How's that going?
You know, this is really interesting to me because it shows the creativity of scientists. So there's a vaccine, for example, that's going to use a live attenuated measles virus vector to transport the S protein. There's 2 companies that are developing oral vaccines. Now, think of how easy that would be in terms of globally mass immunizing people against this virus. And about every other idea that you can think of. My own research group is developing a peptide-based vaccines. And there I think, something on the order of about 300 individuals or groups trying to develop a COVID vaccine.
Faith, hope, science.
Victoria is curious. She wants to know, was the Ebola vaccine made with mRNA technology?
Yeah, no, the difference with the Ebola vaccine, excuse me, is that's a VSV construct, as I recall. And that was also a vaccine, by the way, that achieved licensure very quickly, I think in the space of about 4 years. So a little different vaccine, a very different disease, but similarities to the vectored vaccines.
Yeah.
Sharon wants to know, should a person who has had a positive COVID-19 test, been hospitalized, and is now home, still get the vaccine?
Yeah,
I bet
really
those
good.
people would be afraid, for sure.
Yeah, really, really good question. And let me argue both sides of the coin. The first side of the coin is if they are otherwise immunologically intact, they are probably protected for some weeks to a handful of months. So if you had a shortage of vaccine, you might argue, well, let's put this person on hold for 2 months until we get more vaccine. Having said that, I think the other side of the coin is to say we certainly do know that people seem to lose immunity and become susceptible, at least after getting the actual virus infection, and therefore they should be immunized. We don't have a lot of data on this yet, so I think we're going to still be feeling our way along, and we don't want to have to test antibodies before administering vaccine. So from that perspective, I think the recommendation will be you get a vaccine whether or not you had prior infection.
Last question.
I wish I could have just two, just two. But so I'll give you this one, and then if you're in a good mood, you can let me ask one more. Melissa says, with so many of the general public having mild symptoms of COVID-19, how can you tell the difference within the trials between someone responding well to the vaccine versus someone just being lucky enough to have mild symptoms?
Great question, Dr. Pollan.
That really is a good question. Let me make one comment here, because I get asked about, quote, mild or asymptomatic disease. Mild disease does not mean that you haven't suffered a chronic complication of that you may be unaware of, whether that be myocarditis or inflammation of the heart with subsequent scarring, pulmonary fibrosis or scarring, and a host of other neurologic and other end organ system complications. Now, you're 25 and asymptomatic disease, and you lose 3% or 5% of cardiac function. You may be completely unaware of that. That doesn't mean it won't become important as you get older or have other comorbidities. So just to rest the myth that since I had mild disease, I'm scot-free. I would not depend on that. So then the question is, how do you measure efficacy in that? So what they looked at are people who actually had symptoms. So symptoms would be enough to get you swabbed to diagnose whether you actually developed or had SARS-CoV-2 or not. And that's how the efficacy measures were done.
Yeah, it's a big deal. So
okay, final.
Janelle, quick.
Thank you, because a lot of people are asking this, and I think that Dr. Pollan would have a good answer. Is there any validity to the Facebook report that the vaccine is made from aborted fetus?
That probably came from, never mind, I can't say that. Go ahead.
No idea where somebody would get that idea, because this is a chemically synthesized mRNA. So it involved taking the virus, sequencing it to understand the sequence of letters that compose the S protein, the code for the S protein, and then chemically synthesizing those nucleotides. So no, it has nothing to do with aborted fetuses.
Sometimes what goes out on the internet stays out on the internet.
Yeah.
Dr. Pollan, I want to thank you for being such a gracious guest this morning and helping us so much. And thank you for the great work you and your team have done. It just makes you feel good to be able to visit with you. And I think our audience will feel the same way. It's kind of like listening to Dr. Fauci. Some people just speak the truth. So we're so appreciative.
Well, thank you. It's good to talk with you, and good to work with Dana. I've been on a committee with him. He's a great guy. In fact, do I dare say that if I get the chance, I'm going to try to recruit him to Mayo?
No, you cannot say that.
No.
Florida sounds pretty warm.
Yeah, it does. Well, and we call him Hawkeye, so just know when he's Doc Hawk up in these parts. So anyway,
Please no.
So thanks again for all you've done. Any final comments today?
I just would plead with people, and I do this every chance I get. Please do not be misled by the people who are not scientists and who seek to sway you for their political or religious or economic ideologies. This is a viral infection. It is killing Americans and harming many millions more. The inconvenience of wearing a mask is nothing compared to the preciousness of your health and the health of those around you. So please, please wear a mask.
I think that's right. And just so you know, we're not masked here, but we're in a negative airflow room, and we're 8 to 10 feet apart. Okay, Hawk, final thoughts.
Nothing. That's a mic drop. I mean, perfectly said. And I appreciate so much. Thank you for coming on and being a great messenger all around the nation, especially here in Kansas City for this show as well. Thank you.
Yeah, we'd love to have you back. So to our audience, today you've heard a lot about faith, hope, and science. And sometimes hope has to stand alone. And it can be a powerful thing. But not this time. Not this pandemic. Not at this hour. Because right now, faith, hope, and science are together. They don't have to be at war. Pitting those three at war is a personal choice. It is not a requirement. I'm a man of faith. I have hope, and I believe in science. And when those three things are together, it can deliver us from a crisis that we are engulfed in. It is killing one, it will kill 1 in 700 Americans. Do you know 700 people? I bet you do. Imagine if one of them succumbs to this virus. It doesn't have to be that way. Faith, hope, science, together, united, we stand. Tomorrow we have another great program. Dr. Catherine Satterwhite joins us along with her husband, Dr. Louis Satterwhite, who's a critical care physician. Catherine is the Regional Director of Health and Human Services. And we will also be joined by psychologist Dr. Danielle Johnson to share what they know about vaccine distribution, how the medical staff and our ICU teams are handling all the COVID and their excitement about the vaccine, and also talking about how we can get vulnerable populations to believe in what we're trying to do. This has been a great program. Most of all, it's been about the future. Let's follow faith, hope, and science together and find that future that starts very, very soon as vaccines are starting here in the USA. And remember, there's still no place like home. We'll see you tomorrow.